Hello, my name is John Scott, and I'm coming to you live from Greenville, South Carolina, on behalf of Prisma Health and the University of South Carolina School of Medicine in Greenville. Today we'll be discussing, is weight regain a spectrum, and when do we intervene? So, does weight regain happen? Well, obviously it does, otherwise you wouldn't be watching the slideshow here at SAGES. Other studies have shown, Sugarman showed that the magnitude of excess body weight loss decreases over time from about 66% at 1 to 2 years down to about 50% at 10 years. The Swedish obesity study also showed that about 10 to 20% of patients regain a significant portion of their weight with long-term follow-up. Godot showed that 22% of sleeves failed to maintain 50% excess weight loss after 5 years. Why does weight regain happen? Well, certainly it's a multifactorial situation. There's patient non-compliance. There are physiologic compensatory mechanisms, metabolic imbalances, behavioral changes, inactivity of patients. Postoperative complications can certainly lead to weight regain, genetic factors, and environmental factors. So to tackle the problem of how to deal with weight regain, we have to define what weight regain is. So it really depends on what your definition of success of weight loss after surgery. Some surgeons use a percentage of total body weight loss. Some surgeons use percentage of excess weight loss. Some surgeons use a percent of BMI change or just total weight loss. Well, most surgeons kind of judge weight regain depending on what the nadir of the weight loss is. In 2016, a study was released, and this was a poll of surgeons that were participating in the International Bariatric Club about what the definition of weight regain is. And some said that patients had to re-achieve a BMI of greater than 35 to be considered weight regain. Some surgeons considered any increase in weight, 10 kilograms from the nadir. Some said any weight regain is defined as weight regain and desires intervention. There was a study performed in 2019 that looked at some other criteria for success and failure. And you can see here the definitions were across the board. Some studies recognized a percentage of excess weight, some a percentage of excess weight loss, some used a BMI cutoff. So there are a variety of definitions. A really good study that was performed was a study based on the LABS 2 study of just gastric bypass patients. And the defined weight regain over a function of time instead of some kind of time point. Weight regain is the most substantial the first year after reaching the nadir weight. But you can see here they used a variety of different definitions, and you can see across the board there were different effects for each of those patients. And you can see here either a gain of 10 kilograms or a gain of 5 body mass index points, or a percentage of the nadir weight, or a percentage of the maximum weight loss. So there was a variety of different definitions that they used, but no consensus was reached based on these measures. There was an abstract that was presented at the ASMBS annual meeting in Las Vegas last year, and I thought this was real good. I was moderating the session, and basically they understood that we kind of need to standardize our terminology in terms of weight regain. And so they used the Delphi method to assess a consensus on weight regain, and they interviewed and surveyed a bunch of bariatric surgeons and had an expert panel kind of define what a non-response is. And so they basically broke it down into 2 categories. Primary non-responders were those patients that were unable to achieve adequate weight loss after surgery. And then a secondary non-response category where patients had some excessive weight regain after an initial adequate response. Well, the primary non-response was defined as any patient that had failed to achieve 15% of total body weight loss at 12 months. And then secondary non-response were patients that had 20% regain of their total weight loss at a minimum of 2 years after surgery. And I think there's really good definitions, and I use them in my practice just to kind of standardize where patients are in time in relation to their weight loss. But you can see here, there's kind of a gap. So you can have a primary non-responder at the 12-month mark, and then to meet the criteria for a secondary non-response, according to these definitions, doesn't happen until after you meet a minimum of 2 years of surgery. So when patients are in that 1 to 2 year gap, it's kind of hard to define where they are in time. So the big question is when do you intervene? Well, right now, the evidence that we have is anecdotal, and there's no defined standard of care of when you should respond. And obviously, any weight gain from a nadir is worrisome. And there are risks or benefits for every intervention that you do. You can see here, this was a study done at Mass General Hospital, a retrospective review. And this was all patients that had bariatric surgery that had follow-up with weight loss medications. And this was a 14-year time frame. And you can see here, weight loss medications were not used extensively. They could only find 319 patients. But here's, as far as when to intervene, some patients had interventions 2.1 months after the time elapsed between surgery and the start of their medication. And some patients waited almost 167 months before they got restarted on weight loss medication. So there's definitely a spectrum there of when to intervene. There was another study done that was at the Cleveland Clinic, a study of 209 patients that were intervened between 2012 and 2015. And you can see here the median time interval between surgery and starting adjuvant pharmacotherapy was 38 months. So you have to kind of break it down into non-pharmacological interventions versus pharmacological interventions. So you can start non-pharmacological interventions at any time. Anytime you see weight regain, anytime that your patient has life changes or is having emotional struggles or is dissatisfied with where their weight is, there's a variety of things that we can talk about as far as non-pharmacological interventions. However, in pharmacological interventions, how I do it in my practice, obviously patients that are primary non-responders, I'm going to bring up the possibility of beginning pharmacological therapy. A secondary non-response patients, the same thing. And really, anytime my patients are struggling with their weight, if they start to regain weight or their weight has slowed down, they're dissatisfied with their weight loss after 6 months, and they're requesting help, I'm probably going to reach into the medicine bag and look for a pharmacological agent that can kind of help with their weight loss journey. Some of the non-pharmacological things that you can do, obviously you can have psychosocial counseling, behavioral therapy, dietary intervention at any point in time, and physician-directed prescriptive exercise. And this can happen at any time point. Patients don't have to reach a nadir weight. They don't have to be a primary or secondary non-responder. You can see if the patient's struggling and you have those services available, you can go ahead and get your patient enrolled in some of those interventions. As far as pharmacological things that I do in my practice, I use phentermine, topiramate, phentermine and topiramate, diethylpropion, glutide, and naltrexone bupropion. And if I really want to torture the patients, I'll throw in some orlistat. So what should you do? Well, you can hire an obesity medicine specialist. You can do what I did and consider an ABOM certification to enhance the medical side of your practice. You can absolutely listen to your patients, especially those that you're seeing on a long-term basis. And weigh the risks and benefits of pharmacotherapy for your practice and for your patients, and then have an opportunity to just sit down and talk with your patients and have some shared decision-making. Obviously, any intervention that you want to do for your patient, you got to make sure that your patient wants to do that as well. Sometimes I'll offer medications to my patients and they're not keen on starting a medication, or they're just not emotionally ready for potential side effects for any kind of intervention. So make sure that your patient is willing to take that next step so they can continue on their weight loss journey. Well, enjoy the rest of the session today, and I wish we could be together in person, and looking forward to when this crisis is over. Enjoy the rest of the meeting. Thank you.